Okay, I think we can go ahead and get started. Welcome everybody and happy first day of spring. We are so happy to have all of you here for our second Lemons to Lemonade lecture of 2025. Many thanks to all of you in attendance. I'm seeing some familiar faces in there too, so thanks so much for all of your support. And just so you know, Lemons to Lemonade, we are in our second year. And our presenter tonight, Dr. Cristina Feather, was the first presenter back in April 2023. So we are so excited to have her back. We are also, just so happy to be able to keep this Lemons to Lemonade lecture series going, and definitely want to thank all of you for your support. I would also like to stress that we really appreciate your support of MPHP and what we do. And if you can see a way to extend your support to a tax-deductible donation, that would be so much appreciated. Your generosity is what helps keep this series going. So from $5 to $5,000, we appreciate you. Let me now introduce Dr. Martin Rusinowitz. Marty is one of our of MPHP's medical directors and has been in that position for 6 years, though his relationship with MPHP goes back about 26 years. We are so fortunate to have Marty on our staff. He has just added so much to what we do and what we're able to do for our participants. So thank you, Marty, very much. But Marty is also here to do a little bit of work. He is going to be introducing our speaker tonight, Dr. Cristina Feather. So, Marty, take it away.
Okay. Thanks very much, Margaret. It is really a pleasure to introduce Dr. Feathers. She has a long list of accomplishments, and I'll just start by saying she's an acute care surgeon and is a surgical intensivist at Luminous Health in Annapolis. She's an instructor at Shock Trauma and a certified physician development coach. She attended Temple University School of Medicine and finished general surgery at Temple as well. She returned to Maryland to complete a Master's of Health Science in Clinical Investigation at Hopkins Bloomberg School of Public Health and a surgical critical care fellow also at Shock Trauma in Baltimore. Upon joining the Luminous Health medical staff in 2016, she has been both in the acute care surgery center and critical care teams. In 2021, she was named the inaugural Director of Physician Wellbeing at Luminous Health, aiming to create a physician well-being program for the medical staff to navigate through hardships and promote job satisfaction. During her tenure, a focus on development of support resources and efficiency of practice initiatives, as well as increased assessment and appreciation efforts, have provided her with increasing knowledge of relevant resources for physicians and other medical staff members. Today, she'll be talking specifically about where do we go for help and exploring what resources are utilized among physicians and clinicians in need of support. Dr. Feathers, it's all yours.
Thank you so much. I really appreciate the Maryland PHP for inviting me back. I didn't realize it was 2 years ago, so time flies, but really applaud this program and this series of lectures to get the information across where it's needed. And thank you all for joining tonight. Today, I want to talk about 3 things. 1, why do we need support as physicians and clinicians? Who do we want to support us? And what can we do as a healthcare organization or as a state level organization or across the country to really make sure that resources continue to be cultivated and offered to medical staff? So why do we need support? Well, we can see in this picture that there are very obvious occupational hazards that these workers are doing to build a skyscraper. There are very real threats to falling over, to life and limb, or not paying attention to your partner or making a mistake. And so these are very obvious to the public and obvious to the worker. But what's different about our profession is that they might not be so obvious, not only to our patients and the patients' families, but to ourselves. And so we tend to start learning those as we go through the profession and as we go through our trials and tribulations. And it's important to realize those and acknowledge those. So there are unexpected things that happen. There are complications that happen in everyone's career. They're unavoidable. And so this notion of second victim syndrome has been described and goes back 30 years. And the idea being that there is a first victim, which is the patient and the patient's family, but that also the physician, the APP, that person that's making decisions that affect that patient also experience some of those very similar consequences. And they can be emotional consequences, physiologic consequences, behavioral consequences. And what's different about the patient is that the physician usually, or the APP or the whatever clinician or member of the healthcare team goes on to take care of that next patient, whether that's within seconds or minutes, whether that's within the next week. There's this time of processing that's not structured and not allowed in the past that now we're becoming more aware of that needs to be brought up to our practice. So in 2019, when I began work on physician well-being at Luminous Health, I wanted to look at the resources we had and see, how much people knew about why we would need resources. So I asked some of our medical staff if they knew about second victim syndrome. And interestingly, most of our attendings and APPs knew about second victim syndrome, but when I asked the residents, only a third of them did. And then when we asked if they experienced an event that caused trauma or significant stress, it actually was pretty similar. So it seems like this is an accumulation of pressure that we feel as we go through our career. And we have to acknowledge that and make sure that we teach people about second victim syndrome early on, so we can develop resources that are useful to everyone. This is a study that was done in Spain, and it also asked both physicians and nurses about second victim syndrome. And I find this really interesting because it compares the responses of these two professions that are both part of the same team. So you see here, there are two different healthcare settings. There's the primary care setting and the hospital setting. And so when you ask physicians if they knew of any near misses, almost all physicians stated that they did. So 75% in primary care and almost all in the hospital setting. When if they knew of adverse events with serious consequences, about half in the primary care setting and 80% in the hospital setting. And what I find really interesting is they asked if they had been personally involved in informing patients who have suffered an adverse event. And we know that impacts us as clinicians. And half definitely had in the primary care setting and almost 2/3 in the hospital setting. They also acknowledged that they've known cases of professionals who have suffered emotionally. So we know that there are others suffering from second victim syndrome. When you look at the nurses, you see that a lot of this burden of informing patients about adverse events falls on those clinicians, those physicians, those APPs, where an unexpected occurrence has happened. And it's up to us, it's our responsibility to make sure that the patient and the patient's family have been informed. So how do those things make us feel? Well, we know that as far as our actions after that's done, that we don't really ask for time off. We don't ask for a transfer. We don't leave the profession. But there's a lot of other things that run through our mind. And this was a really good description of the different things that us as clinicians feel when an adverse event happens. This was a meta-analysis and systemic review of second victim syndrome in the intensive care unit healthcare worker setting. So it surveyed both physicians and other members of the healthcare team. These studies included settings in as US, Brazil, and Germany. And overall, 58% reported knowing or experiencing second victim syndrome. 60% of those respondents across the studies stated that they had some symptoms, but recovered within 1 month. And 20% of those stated that they had persistent symptoms at 12 months, which is pretty concerning. So what are some of those prominent symptoms? Guilt and lower self-confidence was highly reported amongst the studies, as well as anger at oneself. And we know that we want help because many people reported the desire to work through an incident for a deeper understanding, and that usually requires a sense of community and talking and going through the event, and they want to get support from others. We know that people feel very anxious, have a lot of anxiety about these adverse events, and they tend to relive the event over and over in their mind. And not surprisingly, we are afraid of judgment from our colleagues, and we tend to be defensive or display overprotective behavior after these events. And we can know subjectively that this is the case, but these studies have shown this objectively as well. So why is this important in our context? We're professionals like anybody else, but we have these occupational hazards that I've just described that aren't in your face. They're not really easily seen, but hidden within our profession. And within that context, we also have to appreciate that we're human. So we have medical problems just like everybody else. And so whether that's a medical problem like hypertension or hypercholesterolemia, mental health also falls within that category. This was a study out of the Lancet in 2021, and it cited that depression amongst physicians was as high as 28%, with generalized anxiety being cited at 24%, and PTSD ranging from 4 to 16%. And this could or could not be due to professional reasons or personal reasons. We know that there's substance misuse and abuse amongst physicians, that alcohol consumption has comparable rates to the general population. We know that there's use of prescription drugs and self-prescribed drugs amongst physicians, and there's an increased risk of prescription drug use amongst physicians compared to the general population with substance misuse or abuse disorders. And we know there's an association between misuse and suboptimal care, and can account for the misuse accounting for up to 5% of medical errors. When looking at suicide in particular, this is the depiction of the rate of suicide over the last few years. You can see there's a bump on both males and females, but interestingly, it's an inverse relationship. So with males, they're a little bit less than the general population compared to other males, and male physicians had a drop in their suicide incidence of suicide around the pandemic, and now coming up to comparable rates. And with females, there was an increase in suicide rates around the pandemic, now coming down to comparable rates with the general population. Now, what are the circumstances preceding suicide amongst physicians? This is where I think physicians and other healthcare workers have a little bit different things to consider, because you can see that a problem with their job is more prevalent amongst physicians. So we know that those occupational hazards have an additive effect to mental health disorders that can be underlying in any of us as humans. Interestingly, we also can see that some studies have cited that those suicide rates amongst physicians are higher when compared to the rest of the world. So we know there are occupational hazards, both that are professional stressors as well as those underlying mental health disorders that we can have. So who do we want to support us as physicians and other clinicians? I think we have to acknowledge the long road that we take as physicians in order to get where we are today. So we spend a lot of time learning. And we continue to learn even after we get into our career. But we spend 4 years in undergraduate, we spend 4 years in medical school. We may spend a little bit extra time between medical school and medical school residency, fellowship. And then our residency fellowship is another area of learning that is stressful and time consuming. And then where all of our undergraduate colleagues have gotten a job 10 years before, have a family, have been paying into retirement, have been saving, that's the time when we actually get a job. And in that category, we have different phases. We have an early, we have a mid, and we have a late career phase that has its own stressors there, according to our experience and also our preparation for that last stage, which is retirement. What does that mean for us as physicians and clinicians? Does that mean part-time? Does that mean full-time? Do we have enough that we paid in for retirement? Does that mean we lose our identity because we spent so much time as physicians? And so we have to remember that when we're talking about resources and other stressors, that we keep in context this very long road that each of us go down. We also have to remember that we have needs like everybody else. This is a really great depiction of how the hierarchy of needs really compares to our needs as healthcare workers. And we see that we have basic needs, just like everybody else. We want to feel hydrated. We want to feel nourished. We want to have a place to stay. We need to feel safe, whether that's job security or physical safety within our building. We want to feel respected from our colleagues, from our organization, from other members of the healthcare team. And then we can get to appreciation and feeling like we're having meaning in our work. So I would say that we have really 3 really important needs, not to say that this is our only basic needs, but really important needs for all of us. One, I think we want a job. That's important to many people, but important to us. We work a long time to get that. 2, we need to have a license. We need to have a license to work. And 3, we want to have time. We've spent a lot of time, a lot of blood, sweat, and tears into getting that job. And now this is the time where we want to enjoy our life. So what is important to remember is that with those basic needs, we will do anything to protect that. And when we have something that's affecting any one of those needs, we can feel very, very isolated. We don't know who to go to for help. We feel like others might not understand our particular situation. And we tend to not ask for help until we're in dire straits, until there's something really, really wrong. So what do physicians think are helpful after medical errors to help them get through it? This was a survey of physicians that asked this question. And this is an important list, and I think we all would agree with the things on this list. One, I think we all want to talk about it. We saw that in the previous studies that I just discussed, but it's important for us to talk about these medical errors. We want to make sure that this responsibility that we feel to our patients and our patients' families that we continue that on and provide some disclosure and apology. And we want forgiveness for that. We want forgiveness from the families. We want forgiveness. We want to forgive ourselves. We want forgiveness from our group and our organization. We operate in this moral context that we want to continue to provide quality care to help patients. And so when a medical error happens, that plays on that and troubles us. And along those lines, we're dealing with imperfection. So we call a adverse event an unexpected event. So, if you think about the other side of that, does that mean all expected events have to be perfect? In our world, that it seems the case, right? If someone says our goal surgical site infection rate is 0%, that's unattainable. Doesn't seem right. Well, medical errors also, zero medical errors, although that is our goal. Unfortunately, these things will happen. But we know that learning from it and becoming more of an expert will help us and help our patients in the future. And that will help us prevent recurrences and improve teamwork. And we want to help others. So I think about, when I'm teaching a resident in the operating room and I say, I usually do this because when I did it the other way, it didn't go well. We're all trying to communicate those pearls that we have experienced and learned over our course of our career. So why don't we go get help? This asks both physicians, attendings, and residents, what is your barrier to going to get help? And you see here, the biggest one is lack of time. Time is one thing that I cited as our basic need. And so we think that going to get help is going to take away from our professional day. It's going to take away from our personal lives, and that's just not something we can sacrifice. We also are afraid about confidentiality, and along those terms, we're afraid about how going for help will impact our career and impact our record, our documentation on our record. We still have stigma over mental health care, and we're still trying to battle that. But also, I think there's still problems on making sure that our medical staff knows what resources are out there. And we want to make sure that those resources are good and valuable. And then you can see some other reasons there for barriers to getting to help. And I'll cite another important one is cost. And I think that's a barrier to all of us. I know Margaret and I have talked about this aspect too. So that's an important one that we have to remember. So when we decide that we want to get help, where do we want to go? Well, I think we're not surprised that most of us can think that a colleague is our first resort, whether that's a faculty colleague or a resident colleague. If we're afraid about confidentiality and afraid about time and afraid about cost, keeping our circles close and going to a colleague is going to be the first place that we go. Then we can really expand our circle a little bit and program director, chief resident, or seek a peer. Our next kind of layer to our onion is this mental health professional and physician health services. But you can see here where some organizations really advertise their EAP as their resources. This actually is very underutilized. I can say honestly, when I started work with well-being, I didn't even know what EAP stood for. That was an acronym I had to learn, and I was already 3 or 4 years into my career. And so that's not commonly known exactly what it is or exactly what's offered. So that's not something as an organization that we can rely on as resources. We have to meet people where they want to be. And so we have to make sure we cultivate these things that people want to use. So I think there's 3 very fundamental things to resources that we have to consider when we're working within an organization to offer this. The first thing is they have to be available to everyone. So available to one department versus another department is going to create mistrust, or an employee versus a non-employee is going to create mistrust. We have to make sure that they're available to everyone, because as you're continuing to develop resources, that trust and resources between the organization and the medical staff member is very, very important. We want to make sure that they're non-threatening. So we're not providing resources as a punishment is one aspect of that, that people are willingly going to get resources, that it's on their own free will, or that they're being suggested this and agree to that. But also we want to make sure that access to resources is not threatening. So that, if I'm in charge of well-being, that people don't have to email me directly to ask me about the peer-to-peer support program, that they can go to an email of peer-to-peer support and feel that they're maintaining their confidentiality. And we have to make sure that our resources are diverse. So where I may think that peer-to-peer support is what I need, maybe my colleague doesn't think that's where it fits for them, and they really want to see a mental health professional. That's where they think that they need that support. And so we have to make sure that we continue to recognize that people's current state are highly variable of where they are in this spectrum of well-being. So let's talk about what support resources we can provide as an organization. Well, we've put in clear that our clinicians want colleagues to help them. That's their first go-to. We see that time and time again. So you have to make sure that you cultivate a medical staff culture that promotes this colleague interaction. We have to have respect between medical staff members, because that sense of community can save some of our medical staff to continue to practice, to get over those symptoms of second victim syndrome and continue to succeed within the medical staff. So some of those things could be things that would improve collegiality, improve togetherness of medical staff, that can be done by the organization. Next is peer-to-peer or coaching. And a few words about this. I think we have many professional roles that we step into, not all with a lot of training. So we train really hard to be physicians or APPs. We have that down. We have some credentials behind that. But all these other roles that all of us play, we don't get a lot of formal training. Educator, mentor, coach, leader, all of those things, we don't necessarily get a certificate of completion for training for each of those. So when I was thinking about developing a peer-to-peer support program, I kind of went through the scenario in my head and said, okay, so I'm going to ask volunteers to be peer-to-peer volunteers, and someone's going to come to me. Am I going to know what to do? Am I going to know how to talk to them? Actually, am I going to know how to listen to them? How do I make sure that our volunteers are well trained to provide some benefit to our colleagues that want help? So I think not only in our organization, but in other organizations that have developed peer-to-peer programs and coaching programs, you recognize that we have to train those colleagues to be able to be good coaches for our colleagues and to provide some benefit. What does that mean to be good coaches? Well, when you're coaching, you're promoting inquiry. So with the coachee themselves, it's helpful to develop sustainable tools. You promote responsibility of learning yourself and some self-confidence, and all of those things can improve well-being. But from the coaching side, you need to eliminate assumptions. You're not here as an evaluator. You're not here as an educator. It's more of a collaborative relationship. And actually, it has been shown that the coach can also have some improvement in their well-being as well. So we know that peer-to-peer and coaching itself can have some really great benefits in the resident world. And we see this time and time again, and more literature is growing about how it can help in medical staff worlds across the way. But I think it's important for us to recognize that training on each of these things are valuable to ourselves and our colleagues. Next, a mental health professional. With my experience of coaching, I see that sometimes you have coaching and you have a peer-to-peer interaction, and people realize through that interaction that they need something more. And it's very important to realize the difference between coaching and a mental health professional. So where coaching is a partnership, like we talked about, and it can motivate and encourage an achievement of a specific goal that's set by that coachee, it's unregulated, and it doesn't really assess, diagnose, or treat mental illness. That is best done by a mental health professional and needs to be recommended if that's the case. And it's regulated by mental health licensure. So coaching and a mental health professional, coaching can be a gateway to really open a colleague's mind to what they may need is a mental health professional. And that's why all of these support resources are important in a stepwise fashion if we're really going to help a colleague that's not really quite there yet to treatment, but knows there is a problem. There are barriers to mental health professionals, specifically in our realm of physicians and APPs. One, we don't want to carry around a diagnosis of mental illness. We're afraid for our job. We're afraid for our licensure. We know that we don't know if that medical insurance coverage will happen, but we also are afraid about our disability insurance coverage because we know that might hurt how insurable we are. And we don't want people to find out. We don't want our colleagues to find out. We don't want our organization to find out. And so people really don't want to seek a mental health professional. We recognize that as a profession, and across the country, there's been a lot of work in this the last 10 years, and Maryland PHP as well as the other PHPs have done this. But I also would encourage everyone to go to the Dr. Lorna Breen Heroes Foundation, who has a great graphic on this. They, along with the AMA, are promoting change in licensure and to make sure that licensing boards are really focusing on the now and instead of the past when we're talking about mental health. So where in the past, AMA has cited that that licensure boards have really concentrated on the overarching diagnosis of any mental health or behavioral condition. The AMA recommends that you focus on current impairments to support that safety, health, and wellness, and to break down those barriers for mental health. So an example would be, are you currently suffering from any condition that impairs your judgment or that would otherwise adversely affect your ability to practice medicine? And the foundation highlights states that have changed their language in order to match that. The second step in that is for that organizational credentialing to do that as well. And the foundation highlights states where organizations have done that. So that takes leadership from the organization, from the CMOs, from the credentialing committee to review your credentialing language and make sure that that language is non-threatening, but also to make sure that your medical staff leadership, and your administration understands what that means to the profession to create those barriers and how breaking those barriers can really provide improvement in your medical staff well-being. And finally, treatment programs. Many in the audience know about the PHP services, but just to review, PHP services can be highly variable across states. So they can provide substance use treatment, mental health, behavioral health, sexual misconduct or boundary violations, physical illness, or stress management issues. And they vary by state on how these are run. Some are government run, some are non-government run across the country. And we know that referrals can come from a variety of resources. So they can be from the board, from the clinician themselves, from the hospital and the employer, or from a spouse or colleague. What's important about these programs is that the clinician is an active participant in this. They're not blindsided by this referral, but they welcome this referral and welcome treatment. And that's really, really important aspect to this resource. So this was a study that looked at the essential components of physician health program monitoring for substance use disorder and what participants that have been successful for 5 years really thought was useful about PHP programs. And you can see that the overall participation was really a highlight of PHP programs, but some other important things like support with finding disorder treatment, attending 12-step meetings, and just the initial contact and intervention of PHP programs was very, very useful. So what can we do to help? What is we as an organization, whatever healthcare organization or practice we participate in, we as a state with state functions such as the Maryland PHP or us as a national organization? I think we have to recognize those occupational hazards. And just like in this picture, there are safety measures that are used to prevent any injury. So there's hard hats and there's harnesses. And we have safety measures in our hospitals to prevent medical errors. But I think we also have to make sure that we're providing safety measures to prevent those long-lasting second victim syndromes consequences. This is a wonderful article of our our past Surgeon General, Dr. Murthy, out of the Office of the U.S. Surgeon General. And it recognized 5 essentials for workplace mental health and well-being. So we see this protection from harm. So we want to make sure that we're safe and secure. We want to make sure that if we go to seek help, that we can have some return pathway that we can see in front of us. We want to feel this connection and community because we know that's important to us when adverse events occur. We want to make sure there's a work-life harmony. Time, as I said, is a basic need, and we want to make sure we provide that flexibility if needed by that clinician. We want to matter at work. We want really to have some meaning and dignity. And we want to make sure that we can continue to grow, whether we need a break from work and come back and grow, or whether we need to grow in other ways within our organization. What's important to remember, right, is if you ask people about what resources would help with your burnout, counseling and check-in doesn't really rank high on the list. But if we remember that cartoon, physicians don't really ask for help until they're in dire straits. So I think we have to really take that into account. We see also here that increased compensation is high on people's lists, and that's really a common answer. But I think we need to remember too that we're putting a lot more priority on our work-life harmony nowadays, and that goes across generations. This is a Medscape survey from 2020, and it talks about if physicians would take a salary reduction for a better work-life balance, and you can see that half of physicians would, and it doesn't matter how old or young they are. And how much of a cut would they tolerate? Well, up to $50,000, which is pretty significant. So we need to make sure that time is given to physicians and make sure that support is available because burnout will happen to all of us at some point, and we need to provide those safety nets. So when we think about our basic needs and how we provide resources to our physicians, we go back to the job, the license, and the time. And we can think of how those resources reflect on each of these things. So first, with a job, we need a sense of community. That's our first go-to for all of us when we need help. And so we need to make sure that within the job of us as clinicians, we're continuing to make that grow. With our licensure, we need to feel some safety. So licensure we know is important, but if we are in trouble, if we need help, that we feel safe to go get those resources and make sure those resources are designed so that that confidentiality is maintained. And with time, we want to make sure that we provide some flexibility. You know, that flexibility can vary depending on context. Maybe someone needs some time off and we can give them that time off and welcome them back in. Maybe someone needs just some time off when an adverse event happens, if we can manage that. So how can we really think differently about flexibility for our clinicians so that they can feel supported and be able to recover? I want to thank everyone for joining again, and thank the Maryland PHP for inviting me. I think this is a really important topic about resources as we continue to develop resources across the state and across the country. And I'm looking forward to any questions or comments. Thank you so much.
Well, thank you very, very much. This has really been a lot of really good information, I think, here. Folks, any questions? Feel free to raise your hand. Feel free to put them in the chat, however you would like to ask. I think, frankly, you gave such a comprehensive overview that, this is great. One of the things that oftentimes, in PHP, at least in the one that we're doing in Maryland, we get to is this kind of overwhelming, I think, stigma around asking for help, and feeling that I'm less than. I'm not really good enough if I ask for it, if I need it. And any ideas about how to, kind of the messaging to support people to feel that that's their right, actually, to get help.
Yeah.
It's not, yeah.
I think setting an example, as we can, the more of us that are experienced, right, that have been through these trials and tribulations and gone to get help, we need to name that. So I discussed with you, I had a colleague that talked about her PHP experience in one of our trauma conferences this year, and it was a total shock to everybody, but it was a great education on what PHP provides, and really depicting how we can continue to succeed professionally with PHP. I talk about my own medical errors and my own mistakes to my colleagues and my trainees, to make sure that people know that all of us have times when we need to go out and seek help. And so I think we need to set an example of what that looks like when we go out and get help.
Thank you. A question in here. The lawyers often disagree with us about what is the right thing to do.
Yeah.
How do we handle that?
I think there has been now more and more literature about how litigation actually decreases when we have disclosure. And so we just have to make sure that we are trained and we train ourselves on what that disclosure means. So, patients, just like we can see when we're not telling the truth, when we're hiding something, and that doesn't sit well with us. And it doesn't sit well with the patient. And so there's more and more discussion amongst us as a physician community on, okay, we know that we need to disclose, we want to disclose. How can we educate ourselves on how best to do that, to make sure that we're continuing our responsibility to the patient and making sure it sits well with us? We don't feel this enormous guilt to get that forgiveness, right? And to close that loop. So I know lawyers are very uncomfortable with that, of course, but now we have some data to prove that actually that might be helpful to organizations to disclose.
Okay, so we do have another question here. Does your organization utilize an outside resource to train your staff on doing peer-to-peer support? That's a great question.
Yes. So yeah, great question. And as we were developing the program, I asked around to neighboring programs on what they did. And the more developed programs that have been in practice of peer-to-peer support for 10, 20 years tend to now have a training program within. But if you're a new program, I think it's very, very helpful to get training on the outside. And there's a lot of resources for that. We use the Physician Coach Institute that provides kind of a short-term peer-to-peer training for healthcare workers. There's a lot of that across the country, and now we can do that virtually. We don't need to travel to do that. And so our volunteers go through that 13 CME credit hour training, and we as an organization financially support them to do that. So I think that's very important if you're developing a program, to make sure that you're providing the right training. And then we go through kind of continuing education internally for our volunteers as well.
That's great. Great. And I just wrote that down. Physician Coach Institute. Thank you. Other questions, comments? Let me ask you, a little bit about something that you and I have talked about, and that's trauma. And how much do you think that trauma, I don't know if that's the right word, interferes with folks accessing services and asking for help and feeling comfortable with it?
Yeah, I think there's a lot more discussion on that now in trauma-informed care. So I think that's improving, but it serves as a huge barrier, especially since we're kind of normalizing this trauma too, since we see it time and time again. And so that's why I think discussion about it is helpful, because all of these things, whether it's, unexpected events or other or traumatic events, we tend to normalize them as clinicians and then just move on. So it's important for us to talk about the effect of those things, so we can talk about what resources other people may need. Because if we just brush them off, I think that we lose the opportunity to highlight resource utilization.
Thank you. Other questions? So I'm going to so thank you so much. Oops, here we go. How did you allocate funding for your programs in the first stages? I'm aware of the ROI, quality improvement, turnover, etc., but given the GBR, I am curious.
Yeah.
So ROI, return on investment.
Yep.
Yeah.
So this is where the article I took that pyramid from, it is fantastic. And the AMA also has really fantastic resources about the business case for well-being. And there is one, right? If you're really trying to campaign for financial support within your organization at this point in time in 2025, it can be really, really hard. But we really capitalize on the fact that it's not just about turnover, but productivity productivity is important to our hospital as well as any hospital. And when someone is not well, they can't produce either. So we want to make sure that the health of our medical staff directly affects our bottom line, and we can show that data with those resources from AMA and some other foundations that have really been helpful to translate that to administration and get financial support. It didn't happen overnight. It really has taken years, and I'm very lucky that I have a lot of support from administration in my organization for this. So I'm very grateful that I think I'm right place, right time within Luminous Health, and grateful to them. But it can be very challenging, and I think that's where you have to make sure that you're doing your research on what are the financial costs of burnout and poor well-being amongst your medical staff.
I think, we're always going to, say that that investment in all of that is always going to pay off, always. For hospital-based physicians, is there an expectation to go in-house for support or care? And a related question, is there a difficulty with provision of time for care if one goes outside?
So I think the big barrier for in-house care is that it's sometimes not there. So a lot of organizations just have EAP, which is very limited. Usually it's 4 to 6 sessions with a mental health counselor that might not be specialized in healthcare in particular. So a lot of people have to go outside of their organization in order to get help. And that's where people have more barriers because they don't really want to use their insurance to do that, because then it might be on their health record and they don't know who can see their health record. I've had many residents ask me about that and being worried about that. So I think most people go out of their organizations when they need a mental health counselor. That's why peer-to-peer support, I think, is so important, because it can be a bridge to that. So if people don't want to step out into mental health counselor or treatment, but know there's a problem and feel safe going to a peer-to-peer, though our peer-to-peer supporters at Luminous Health also try to direct people to resources that are appropriate. So it can be just another form of information for people to get resources.
Thank you. Other questions? So again, I'll kind of interject here about the Maryland Physician Health Program. Thank you so much for talking about PHPs and the work that we do. I think that across the United States, they have really proved themselves to be essential supports for the provider community. We of course unfortunately can't do this for free, and as you mentioned in your presentation, cost is definitely something that we need to consider. So we do have costs for our PHP has costs for intake, which is a pretty comprehensive process. And then we have a monthly ongoing fee for monitoring. And then if random toxicology is indicated, then that is extra. The thing that we do, and I think that many PHPs across the United States are able to do as well, is offer some level of financial assistance. This is not something that insurance companies will reimburse you for. They don't, I mean, we can't take, third party assignment of benefits. We don't also, this RPHP does not provide any clinical services. So we don't, we don't do therapy or run, group therapy or do medical evaluations. So those things are all extra outside of all of this. So we realize it can, get fairly expensive. And we're there to support as much as we can. But there's no getting around that. Many of the very good programs that we recommend for folks who are struggling are sometimes are not covered by insurance and are quite pricey, quite expensive. How we get around that, I really can't say. But yeah, that's the lay of the land.
Ideally, and it's not as extensive as PHP, but ideally healthcare organizations offer in-house counseling at least, right? Because that's a service to the medical staff, and it doesn't need to be on your health record. And so a lot of organizations that are really developed in their well-being program offer that in-house. That's our ultimate goal, but again, that costs money. And as we talked about with the previous question, financial times are hard for healthcare systems in Maryland and across the country. But that would be the ideal state too, is to provide, as Margaret said, make sure that we can continue to provide financial support for resources as well, because we recognize that's a huge, huge barrier.
It is. And I think that my hope is that in the future we'll be able to find some creative ways of funding things. Whether that's finding a deep pocket donor, which I'm still looking for, by the way. So if you know of anybody, but how can we support each other and see how the future unfolds? I think we're all a little cautious. Any thoughts on how to frame in-house counseling as confidential? We see a pushback by participants, sometimes out of fear of lack of confidentiality within the workspace. We've seen that especially with EAPs and
Yes.
yeah.
You know, people, even though you tell, your colleagues that it's completely confidential, people continue to have worry about it. So it's definitely a concern. I think the best way is to continue to foster that trust. So if you're having a mental health counselor, they don't report necessarily to the CMO, right? They don't report to any sort of body that is overseeing quality. And to make sure that they are in a separate well-being space where they're isolated. There are now third-party contractors that contract with hospitals to provide such a service. They're very, very costly though. So where they provide kind of an all-encompassing service, there's counselors, there's psychiatrists, they even can prescribe medication but don't need to have a diagnosis. They're very costly to hospitals, and I don't think doable for hospitals. If you have a medical staff as large as ours, that's just not going to be cost efficient, and an in-house person is really the way to go.
Yes, we have also looked at some of the wellness options that are somewhat less expensive. For anybody that knows our program, they may know that we work with Cabana, which is an app that was specifically developed for healthcare professionals. It was actually initially developed for military, and then an offshoot for healthcare professionals. It includes live groups as well as some of the things that these wellness apps include. That may be another way to get some support, some help, kind of on your time, and but also with Cabana, the live groups mean that you can be part of a community and interact with community.
Yeah.
Any other? Oops, great. The American Foundation of Suicide Prevention has an interactive screening tool, ISP, that systems and hospitals can use to provide anonymous support to their staff. Actually, yes, we are very familiar with the ISP, and here in Maryland, we looked at whether or not we could incorporate that. And it is something that's that we are still considering. But yes, absolutely. If anybody knows about that, it's an excellent excellent tool.
Yeah, thank you for bringing that up.
Okay, this has been great. Great questions, great discussion. Anything else? Well, I do want to say, if anybody thinks of anything after we have ended this evening, feel free to communicate with me. I think everybody knows how to get in touch with me. Everybody should have my email address. Please feel free, and I'm happy to pass things along to Dr. Feather, or if it's something that I can help with, by all up. And thank you, Cristina, for putting that in our chat. Christina's put her email address in there. So if you do want to reach out, if there's more thoughts about this, we're always looking for other things that we can do as a PHP that are value added as we're helping providers. So if you've got great ideas, I definitely want to hear about them. So, all right. Well, thanks very, very much for joining us this evening. Please look for notices of our next lectures in April and June. If you were in our waiting room, you probably saw the slides in there that talk about our upcoming lectures. Please consider donating. If you were in the chat, you saw the link to our donation page. Also, as I said before, this lecture and all of our other lectures are on our YouTube channel. And John, I think, is going to put that link in the chat as well. Thank you very much. So look on the YouTube channel, not only for the lectures, but also some testimonials and some statements by our staff. It's really a great place to learn about MPHP, but then also to learn about Lemons to Lemonade. So again, I cannot thank you enough, Cristina, for being here, for being our kind of like our repeat presenter 2 years ago and again tonight. This has been wonderful, great topic and lecture, as somebody just put into the chat. And thanks to everybody who has been in our audience. Thanks so much for your support. Have a wonderful evening and a wonderful start to spring. I don't know about anybody out there, but it was storming like I don't know what during your talk, but now it just seems to have like gone away. So
Guys have opened, yes.
yes. So good time to end. So thanks very much, everyone.
Thank you.
Good night.